detailed side of things. In terms of the national ADAP budget, the overall budget has increased over the last year, but and you'll see the various components that it's made up of, and there are many factors of growth in the ADAP budget. However, one of those factors has not been the federal share of the budget, the federal appropriations line generally. And in the next slide, you'll see that the federal share of the national ADAP budget has decreased from 67% in FY 2003 to 49% in FY 2009. So when this program first started, it was pretty much a federal appropriation program, and that was it. And then over time, states really started to put money, general revenue money into it. There have been negotiations with pharmaceutical companies to give additional rebates, and so you'll see that these other components became larger as a percentage share of the budget of ADAPs. Just a few more slides about the budget, and I probably won't go into this one because it's really small up there, but the bottom line is sort of the federal share of the overall budget, and so you can see how it grew tremendously. It's a much larger share, and then it has decreased from this year. The ADAP earmark, what ADAPs receive through the Ryan-White appropriations, has remained relatively level over the last several years to the detriment of the program. And then state funding, I had said that states view this as a federal-state partnership, and they very much do. However, we hear the stories all the time, and I'm sure you all are from states that are having their own budget challenges. And so the next slide will show the very large decrease that we saw in terms of state contributions to the ADAPs from FY 2008 to FY 2009. It was a 34% decrease. And up until this point, ADAP states have been generally giving more and more each year into the programs to it being a really good percentage. And then in the state crises, unfortunately, some states had to pull out their support for the program. The other large component of the overall ADAP budget is pharmaceutical rebates. ADAPs are relying more heavily on these rebates and discounts from the pharmaceutical manufacturers to maintain their programs during this time. Drug rebates accounted for almost $500 million, or 31% of the national ADAP budgets, and they're increasingly a large component of the overall ADAP budget. So, why we're all here. We heard Brandon earlier talk about the ADAP crisis. My NASTAD tracks every week the ADAP waiting list and the cost containment measures to ensure all the advocates and all of you Congressional staff have the most up-to-date information about what's going on in your state to the extent that we can. So you'll see the states with waiting lists there. They're also, ADAP waiting lists are obviously the most stark and pregnant cost containment measure that ADAPs use. However, they're not the only one. There are any number of other cost containment measures, lowering eligibility, reducing formularies, and all of these things have impact on access to care and the quality of care and the comprehensiveness of care that people receive through the ADAPs. And so the next slide sort of shows the variety of cost containment measures that we've seen instituted over the last year and a half. And we know that many states are looking at additional having to institute additional cost containment measures. Something that is particularly alarming and has happened, has begun to happen more and more. The states will often reduce their eligibility as a cost containment measure, and the next slide shows the states that have in the last year and a half. In some of these states, not all of them, in some of these states, what they have had to do because of their inability to maintain their programs is that they actually disenrolled clients when they lowered the eligibility. That is not something that happened across the board, and it's really something that we have not seen before. And so those people would show up in the waiting list numbers. because they would no longer be eligible for the program. And so I think that is also important, that the waiting list number is a stark picture of need, but it is not the only need. People have been disenrolled from the programs, and additionally, you know, if Rhode Island is now at 200% at federal poverty level, if you make 230% of the federal poverty level, you're not eligible for the program. And so there is a lot of need out there that isn't quantifiable in the same way that waiting list numbers are, but we shouldn't forget that there is this additional need as well. So the waiting lists, 3,214 individuals in 9 states. And we'll talk a little bit more about the $25 million in emergency ADAP funding, but this did allow 4 states to eliminate their waiting lists. However, it is unclear how long they will be able to not have a waiting list. Solutions. We all like to be solutions-oriented. So there's a sort of 3-pronged strategy to the ADAP crisis and the solutions that are needed. We need to look at the federal government. We need to look at state governments. They have a responsibility to restore their contributions to ADAPs, to increase their contributions, or in states where they haven't given before or give very small amounts, they need to be encouraged to step up and give more. And then the third prong of that stool is our pharmaceutical partners, and we'll hear a little bit about that as well. All ADAPs need increased funds to deal with the increased demands. It's not that just the states with waiting lists or cost containment measures are the only states that are seeing increased demands. Pretty much every state is seeing increased enrollment into their program, and so we need to shore up these programs in a little bit of a more holistic way than we have been doing. ADAPs still need $101 million in emergency FY10 funding. FY11, we've calculated that ADAPs would need $370 million. The House and the Senate have proposed increases of $25 million, in addition to continuing the emergency $25 million that was sent out to ADAPs last month. But we know that many states are increasingly worried about maintaining their current clients through the end of the ADAP fiscal year. And the ADAP fiscal year is different than the federal fiscal year. It goes all the way through the end of March. So that's still many months away. In early July, HHS announced the availability of $25 million in emergency funds for ADAP. Brandon talked about the community had been advocating for $126 million in emergency funding for some time. The White House very clearly heard our calls and heard our increased pressure, but didn't get the entire message, and we got $25 million instead of $126. Obviously, these funds are very appreciated and very necessary, but it's not going to make these programs whole. The money went to states with waiting lists and those who would put in place cost containment measures. 30 states and territories were awarded money at the end of August. Awards ranged from $38,000 in Alaska to $6.9 million in Florida. The $25 million, in combination with the Part B supplemental awards, which will be going out to states next week or at the end of September, will allow some states to clear their waiting lists. 4 states have reported doing so, but one of those states, Iowa, cleared their waiting list and capped their program again on the same day. So they had enough money to bring their waiting list clients into the program from that 25, but they did not have any additional dollars to bring any new people into that program. $25 million just is not enough to afford the states to do that. Excuse me. State budget cuts have hit HIV programs exceptionally hard, and earlier you saw the decrease from state funding just to ADAPs. But what you'll also see is that within state public health programs, the public health workforce is being hit very hard by these budget crises. So there's hiring freezes, there's unfilled and open positions. There's positions that have been eliminated in the HIV/AIDS programs in the states. There's mandatory furloughs ranging from 1 to 36 days a year, which 36 days, I mean, that's pretty significant, and it really impacts the ability to manage programs efficiently and to respond to all the requirements and demands that come upon manufacturing or administering a program. So not only has the state funding specifically to the ADAP program really decreased, but in terms of the public health HIV infrastructure, the state crises are also really affecting the workforce, which obviously has impacts on programs as well. We are hopeful that states will begin to restore some of these cuts, and that remains to be seen. But we have seen some recent successes. The North Carolina governor and legislature appropriated an additional $14 million, which brings their state total to $25 million that they put into their ADAP. And that's a very large percentage of their overall ADAP budget. And then we know a variety of other states have reported that their states have maintained or increased funds for ADAP. And I think in this time of fiscal tightness, we can consider maintaining contributions a success. But we do also need to look at those states that have cut their contributions and try to urge them to get back to where they were. The pharmaceutical response. NASTAD convenes the ADAP Crisis Task Force, which is a group of AIDS directors and ADAP coordinators who negotiate with the major manufacturers of antiretroviral drugs on behalf of all ADAPs to provide deeper discounts and increased rebates and price freezes to the ADAPs. Since the task force began negotiating in 2003, ADAPs has saved over $1 billion to this program. And that's money that therefore allows them to serve additional clients. In May, the task force asked all the manufacturers to come to the table, even if they had current negotiations and agreements in place, to say, look, ADAPs are really in a time of crisis. You need to do more. We're asking federal, state, everybody needs to do more at this time. And so the task force has reached agreements with the 7 of the 8. The last one is a very small manufacturer, and those negotiations are ongoing. The task force has also worked with the manufacturers to expand the reach of their patient assistance programs, and we know that is how many clients on waiting lists are accessing medication. It's not that it's the best way to access medication, it leaves people to fall through the cracks, but it is the way. And so working with the companies to make sure that their patient assistance programs are easily accessible and meet the needs of the people who need them. There is also a unique patient assistance program, Vista, that companies are being asked to join, that is the single point of entry for individuals on ADAP waiting lists, so that you don't have to apply to each company's patient assistance program, because we know that some clients have multiple applications to fill out. So, solutions. Obviously, we need more grassroots efforts at the state and federal level. People aren't hearing enough about how this program needs to be saved. The community is working very hard with the administration and Congress to continue to figure out how we can get getting funds above that $25 million to go to ADAPs now. And as Brandon said, it really doesn't matter to us how it happens. You know, I've listed Senator Burr and Coburn's bill up there. It's the only really tangible thing to talk about. But we know, I mean, the $25 million, they found that money from somewhere. Maybe they can find us a little bit more.